The lumbopelvic hip complex has between 29 and 35 muscles that attach to the lumbar spine or pelvis. The LPHC is directly associated with both the lower extremities and upper extremities of the body. Because of this, dysfunction of both the lower extremities and the upper extremities can lead to a dysfunction of the LPHC. In the LPHC region, the femur and the pelvis make up the iliofemoral joint, and the lumbar spine and sacrum form the lumbosacral joint. These joints anchor many of the myofascial tissue that have a functional impact on the structures. Some muscles included in the LPHC are biceps femoris, medial hamstrings like semimembranosus and semitendinosus, and the rectus femoris, which are all anchored by the talocrural joint. There are many impairments that can be present within the LPHC, like excessive forward lean, low back arches, low back rounds, and an asymmetrical weight shift. For the purpose of this video, I will be talking about the asymmetrical weight shift and the steps to take to improve this movement. An asymmetrical weight shift is exactly how it sounds. During the overhead squat assessment, from the anterior and posterior view, you can notice that there is a side-to-side shift. This is caused by an overactive and underactive muscles within the LPHC on the same and opposite sides of the shift. I will be outlining the specific muscles later in the video. For now, we are going to look at the systematic assessments to tell us more about this impairment. The first systematic assessment completed was the static postural assessment. This is how an individual physically presents themselves in stance, which is reflected by the alignment of the body. The use of this has been a basis for finding muscle imbalances for years. A static postural assessment provides excellent indicators of problem areas that might be further evaluated in order to clarify the problems. Postural assessments require observation of the human movement system. The checkpoints include foot and ankle, knee, the lumbopelvic hip complex, and cervical spine. For the anterior view, the feet and ankles should be parallel, the knees above the toes, pelvis level with the iliac spine, shoulders aren't elevated, and the head is in a neutral position. For the lateral view, the foot, ankle, and knee should be neutral, the pelvis is neutral as well, and there is a normal kyphotic curve in the shoulders. Posteriorly, the foot and ankle should be straight and parallel, the knees should be neutral, the pelvis is level with the iliac spine, shoulders aren't protracted, and the head is straight and neutral. The next movement was a transitional assessment. The client completed the overhead squat assessment, which is designed to assess dynamic flexibility, core strength, balance, and overall neuromuscular control. The individual was instructed to stand in a comfortable position, feet about shoulder length apart, and their arms up close to their ears. She was then instructed to squat down like she was going to sit in a chair. The anterior kinetic checkpoints include the feet remaining straight with the knees tracking in line with the foot. As you can see from this anterior view, the hips are not in line with the kinetic checkpoint, resulting in an asymmetrical shift on the right side. Laterally, the tibia should be in line with the torso while the arms stay in line by the ears. From behind, the arc of the foot should be visible, the feet should be straight, and there should be no shift in the LPHC. As you can see there's a shift on the right side. A potential overactive muscle could be her TFL on the right side, and an underactive muscle may be the adductors on the left side. The next assessment was a single leg squat assessment. The client was instructed to squat down to a comfortable position. The point of this was to look for inversion of the knee, hip hikes, or hip drops, or the torso rotating inward or outward. Results showed that her right knee moved slightly inward, but there is no concern with the LPHC. Range of motion is the amount of motion at a specific joint. The first range of motion test was hip abduction on the same side of the shift. The muscles being assessed here are the adductor complex and the medial hamstring complex. The client is positioned supine with the knee extended and the hips are neutral at 0 degrees. After the goniometer was placed in the correct position, she then abducted her leg until the first restriction. The degree of abduction was at 30, which would be limited because of her asymmetrical weight shift during the overhead squat. Normal value is 40 degrees. The next test was internal rotation of the hip. The muscles being assessed here are the piriformis and the hip external rotators, as well as the gluteus medius. The client was positioned supine with her hip and knee at 90 degrees. The goniometer was placed and I passively rotated the femur internally until the first restriction. The hip internal rotation result was 30 degrees, which normal value is 45. There was a restriction due to her asymmetrical weight shift during the overhead squat and her knee moving inward during the single leg assessment. In the picture above, you'll be able to see normal range of motion values for the hip abduction and hip internal rotation. The next thing that was performed was a manual muscle test, which is used to test the recruitment capacity and contraction quality of individual muscles or movements. NASM uses a 3-point grading scale, 3 being normal, 2 points if the other muscles are being used, and 1 means there's little to no activity. The first test was for the adductor complex on the opposite side of the shift. Muscles being assessed here are the adductor longus, adductor brevis, and the gracilis. The client is supine with the hip flexed and knee extended. I stabilized the opposite leg and applied gradual increasing pressure while the client held the starting position. I scored the client with a 2 because there were signs of other muscles being used. Potential overactive muscles are the piriformis or the gluteus medius. The next test was the anterior tibialis. I tested this because it's a potential underactive muscle during the overhead squat. Potential overactive muscles, when strength is limited, are the gastrocnemius and the soleus. The client's knee was flexed and ankle was in dorsiflexion. I then applied pressure pulling away from her and she held the starting position. I graded this movement as a 3 as there are no concerns here. The last test I performed was the gluteus medius manual muscle test. The client is positioned in a side-lying position with the hip slightly extended and the knee extended. I supported the hip while the client held this position after applying pressure to the lateral aspect of the lower leg. I graded this as a 2 due to compensations of hip internal rotation. This may be caused by the limited range of motion measurement for hip abduction. Now we get into the corrective exercise continuum. This includes 4 primary phases: inhibit, lengthen, activate, and integrate. Corrective exercise is used to describe the process of neuromusculoskeletal dysfunction while developing a plan of action and then implementing that plan to then correct the wrong. Here, we are focusing on the asymmetrical weight shift, so the plan is to hit those overactive and underactive muscles to try to correct it. The first phase is to inhibit. An inhibitory technique used is self-myofascial release. The reason for inhibiting is to decrease overactivity of muscles. Some potential overactive muscles for an asymmetrical weight shift include adductors, TFL on the same side, piriformis, and the biceps femoris on the opposite side. SMR is believed to stimulate the receptors through sustained pressure at a specific intensity, amount, and duration to produce an inhibitory response to the muscle spindle. For this technique, we used a foam roller, but for smaller muscles, you can use lacrosse balls or handheld rollers. Here, I had the client roll out her right TFL using a foam roller. After getting into position, she was instructed to hold the trigger point for 30 seconds. This will then release that trigger point and loosen up the muscle. The second phase of the continuum is lengthen. A lengthening technique I used was static stretching. Static stretching combines low force with long duration using autogenic inhibition. This form of stretching allows the muscle to elongate. The point here is to lengthen the overactive muscles. The muscle I chose to assess here was the piriformis. The client was instructed to lie supine and lift her leg over the other while pulling down on the same knee. She held the position at the first point of tension for 30 seconds. Other muscles that could be tested here are the TFL, biceps femoris on her left leg, and her gastrocnemius. The third phase of the continuum is activation phase. The first 2 phases were meant to release pressure on the overactive muscles. This phase targets the potential underactive muscles during the overhead squat assessment. Activation refers to the stimulation of underactive muscles. It's important to re-educate the underactive muscles as well, because the human movement system includes both over and underactive. Some underactive muscles included are the gluteus medius on the same side and adductors on the opposite side. The best way to come about this technique was to use positional isometrics. This incorporates isometric contractions performed at the end of range of motion of the joint. The purpose is to increase the intramuscular coordination of specific muscles to heighten the activation levels before integrating. Here we tested the adductors on her left leg. I was able to hold her bottom leg down and put tension on the lateral side of the foot and ankle of her other leg. 4 reps were performed. Each rep consisted of a 4-second isometric hold at 25%, 50%, 75%, and 100% of maximal voluntary contraction. There was also a 2-second rest between contractions. The last phase of the continuum is the integration phase. Once the appropriate muscles have been lengthened and activated, we can now integrate dynamic movement. Integrated dynamic movement enhances the functional capacity of the human movement system by increasing multiplanar neuromuscular control. The exercises done here focus on synergist function of the stabilization and mobilization muscles. It's vital to use the multi-joint exercises in all planes of motion from both bilateral and unilateral stances to help increase intermuscular coordination. As you can see from each view, there is no asymmetrical weight shift. When looking at the anterior view, the knees are in line with the feet. The pelvis is no longer shifted to the right. The ball helps the client stabilize the spine and keep good posture while squatting. Doing this exercise for 10 to 15 reps will be ideal when correcting an asymmetrical weight shift.